Hello and welcome to this instructional video on the basics of peripheral intravenous cannulation. My name is Tim Nolman and I'm a Senior Anaesthesia Registrar in Wellington, New Zealand. This procedure will be relevant to those students in 4th year medicine and for those soon to be entering the clinical environment who will be placing intravenous cannulae in patients. Peripheral intravenous cannulation is an essential skill for junior doctors, and this video aims to overcome the nerves associated with mastering this procedure, which you will rely on most days for the rest of your careers. By establishing an evidence-based standardised approach to procedure setup and conduct, and practicing on task trainer mannequins, you will find the skill easier and easier with further real-world practice. This video is to be used in conjunction with practice on task trainers in a simulated environment before the use on real patients or other students. The aim of this video is to guide students to insert peripheral intravenous cannulae in a simulated environment. The objectives of this video are to outline the equipment required for intravenous cannulation, and 2. Demonstrate the core steps for intravenous cannulation using the Blatz technique. Intravenous cannulation is a potentially painful and invasive procedure, and there are verbal techniques such as distraction and non-verbal techniques such as the use of local anaesthesia available to make this more tolerable for your patients. However, this is outside the spectrum of this video. Similarly, complications of intravenous cannulation and their management is also outside the scope of this video, and you can refer to these in the references provided at the end. Let us begin by recalling the venous anatomy of the upper limb to refresh our memory from 1st and 2nd year anatomy. Intravenous cannulae are placed in the superficial venous network of the upper limb due to its convenience, their relatively straight course, and their prominence compared to the lower limb. The two main venous drainage systems are the basilic vein on the ulnar side and the cephalic vein on the radial side. These two systems converge in the antecubital fossa with the very prominent median cubital vein, which is most commonly used for venipuncture. On the dorsal side of the hand, the cephalic and basilic veins commence in a network of superficial veins, the most prominent being the basilic vein over the 4th metacarpal bone. Now we've reminded ourselves of where to place these cannulae, let's look at the equipment that we need to perform intravenous cannulation. Intravenous cannulation is a skill where we observe standard precautions and use an aseptic, non-touch technique to minimise risk of microorganism transmission. This means we implement the same infectious control procedures to all persons irrespective of infectious status. Can you remember from previous study what constitutes standard precautions? This includes hand hygiene, using alcohol hand gel before and after the procedure, the use of non-sterile gloves, face mask and eye protection, and a disposable gown. You will also require a yellow sharps disposal bin immediately nearby. This is a standard preparation tray for intravenous cannulation. Moving in a clockwise direction, a limb tourniquet, an antiseptic wipe of alcohol, the cannula itself and extension tubing, saline to confirm intravenous placement, a transparent tegaderm dressing, and gauze, as this can be a messy procedure. This is a standard Insight cannula used in our institution. The components are the needle with an upward-facing bevel, the plastic cannula or catheter, the cannula hub, the flashback chamber, and the cannula plug. If you look closely at the needle, you can see that the tip is 1 to 2 millimeters from the cannula. I want you to remember this important piece of information for when we discuss the Blatz technique. Build a rapport with your patient and obtain consent for cannulation, explaining what you will be doing and why. Most patients will opt for their non-dominant hand to be cannulated. Position your patient with the entirety of the upper limb exposed, with their arm well supported on a cushion or pillow. Apply the tourniquet to the limb at least 10 centimeters above the site of your cannula. Ideally look for superficial veins, distally first, then move up the arm. Before we go on, can you remind me, what equipment would you have ready? I will now demonstrate the procedure in full, then break down the procedure using the Blatz technique. Now let's go over this using the Blatz technique. Cannulation is a skill performed using your dominant hand with skin and vein counter-traction provided with your non-dominant hand. You should aim to enter the vein at an angle of about 20 to 30 degrees to the skin. When the needle enters the vein, blood will fill the flashback chamber. This is called the primary flashback. Now lower the level of the cannula to almost flush with the skin. Slowly advance the cannula into the vein about 1 to 2 millimeters to ensure the plastic cannula as well as the needle is in the vein. Now advance the cannula sheath into the vein, keeping the needle steady, advancing the sheath all the way to the hub. Remove the needle and immediately dispose in a dedicated bio-waste sharp spin. With your finger over the vein proximal to the cannula, you may now release the limb tourniquet. With your IV extension tubing connected, you can secure the cannula with a clear adhesive dressing, ensuring that you can see the cannula entry point. Your cannula should be flushed with normal saline to ensure patency and there is no discomfort with use. This should be followed up by dated documentation in the notes about cannula size and site. So, I would now like you to repeat these steps aloud as you watch this a third time. Rewind the video if you think you need a refresher. This video has demonstrated a basic approach to peripheral intravenous cannulation. Can you remember the equipment needed for cannulation? Can you recall the steps using the Blatz technique? As the old saying goes, practice does make perfect. And I would encourage you to continue to practice this skill on task trainers until you feel comfortable with the equipment and the Blatz technique. Included here are some references and recommendations for further reading and tips on peripheral intravenous cannulation. Good luck out there.